So, good evening, ladies and gentlemen. Today, we are going to talk about the use of dabigatran in COVID-19. So, the scope of today's discussion is we will try to understand why do we need anticoagulant in infection of COVID-19, because there have been a lot of controversies about use of anticoagulant in COVID-19. Should we use or not? Which should we use and when should we use? So this is precisely what I'm trying to address today in my talk. So let us understand what's the connection in between COVID-19 and thromboembolism. We all have been knowing about different viral infections and derangement in the coagulation profile leading to different petechial or different thrombosis or different intravascular events occurring with them. What we have learned over the past 1.5 years with this COVID-19 infection, which is caused by SARS-CoV-2, it predisposes patients to thrombotic diseases, which can be both venous or arterial, and the cause is excessive inflammation, platelet activation, endothelial dysfunction, and stasis. So we all know that inflammation is one of an important cause for activation of the platelet and increment in the coagulation cascade, which leads to thrombosis even in other cases also. And we have been seeing such cases in our ICU since long. Now, there is something special about this COVID-19 and coagulation. We all know that atrial fibrillation is one of the important factors for thromboembolism. We have been using anticoagulants in patients with atrial fibrillation to prevent vascular events, including CAD, including embolic events, including stroke and others. So there has been incidences that atrial fibrillation is a frequent complication among patients with severe coronavirus disease or COVID-19. So in a survey performed in 76 countries, 1/5 of the respondents reported that atrial fibrillation was a common incidence in hospitalized patients with COVID-19. Patients admitted to intensive care had greater risk of new onset atrial fibrillation and what often we call that non-valvular atrial fibrillation, which is being precipitated by COVID-19 in ICU. Atrial fibrillation is not a direct consequence of COVID-19, but it's a result of systemic illness which is produced by COVID-19. And those patients of COVID-19 who develop thromboembolic event, the rate of death was higher in them, and this was seen more in patients with pre-existing cardiac diseases. So this is what it was reported in drug context in September 2020. So what were the factors which were found to be associated with atrial fibrillation in COVID-19 patients? We have to identify the patient population within COVID-19 cases who are predisposed for atrial fibrillation. Because once we use anticoagulant, we should be able to justify its use. And justification can be based only on the incidence or risk of thromboembolic events. So we need to find out the population of COVID-19 who have severe pneumonia, who have hypoxia, electrolyte abnormalities, dehydration. That is one of the common cause that leads to hemoconcentration and increased thromboembolism. Systemic inflammation, we have already discussed about how it precipitates the coagulation cascades. Metabolic dysfunction, activation of sympathetic system, high interleukin 6, once again telling us about the status of inflammation, leukocyte infiltration in arterial tissue, reactive oxygen species. These are the factors which are associated with inflammation, and wherever there is systemic acute inflammation out of proportion, there are chances that patient may develop atrial fibrillation during their hospitalization. Now, there are some other factors which predispose COVID-19 patients for higher risk of venous thromboembolism, which is not limited to atrial fibrillation. So what are they? So ICU admission, cytokine storm, lung injury, pre-existing cancer, obesity, male sex, age, comorbidities, and inflammation. So these are the risk factors. I would once again try to re-emphasize on the fact that this is something that we have been knowing. This is something that we have been seeing in patients who were admitted to ICU with sepsis. Now we need to correlate these factors with COVID-19 patients also. And COVID-19 patients who are having these acute problems, including ICU admission, in the background of these risk factors will always have higher risk of venous thromboembolism. Thus, we can understand that there are some specific thing that has to be understood to emphasize the role of anticoagulants in patients of COVID-19 during this pandemic. It has been seen the risk of ischemic stroke and death among new cases of atrial fibrillation was higher compared to that in 2019. So, since risk has increased, so we need to understand what the cause is. We have talked about COVID-19 causing systemic coagulation activation, which increases the risk of developing both arterial and venous thrombotic complications through systemic coagulation activation, and that leads to increased mortality. Now, this is a beautiful cartoon which is illustrating about the postulated mechanism for coagulopathy and pathogenesis of thrombosis in COVID-19 patients. So at one part, we can see the risk factors like acute illness, bedridden. We have been seeing patients of heart failure who are bedridden more than 5 days. We have been using anticoagulant low molecular weight heparin. Bedridden patient for surgery of bigger joints, we have been using it. So these are known risk factors. We need to identify them when we are having a patient of COVID-19. Apart from that, genetics, fever, diarrhea, once again causing hemoconcentration, sepsis leading to activation of the inflammation, liver injury, CKD, COPD, heart failure, malignancy. There are many malignancies which causes procoagulant state. So these are the risk factors which we have to identify in patients of COVID-19 so that we can prevent any untoward incidents which may be precipitated by thromboembolic diseases. Apart from that, some inflammatory response which needs to be discussed here is lymphopenia, which we have seen is common, that is increase in NLR, that is neutrophil lymphocyte ratio. We all have been talking about it, that if NLR is more than 3.3, there are higher risk of complications than inflammatory cytokine, increase in interleukins and CRP. Hemostatic abnormalities, which have been seen with SARS-CoV-2 infection include pulmonary microthrombi. There has been a lot of discussion about hypoxia, which is mostly because of the microthrombi occluding the microvasculature in pulmonary areas, which leads to improper ventilation perfusion. We have seen cases where we are ventilating patients with high flow oxygen. There is no apparent heart failure. Still, patients have hypoxia. So we tried to understand what is the cause of hypoxia, and it was seen that it is because of ventilation perfusion mismatch. And despite adequate ventilation, because of microthrombi present in the lungs, the perfusion was not adequate, leading to improper oxygenation or poor oxygenation. So, despite giving high flow oxygen, 100% oxygen with apparently no heart failure, we were having consistent hypoxia in these patients. And thus came the theory that it is most probably because of the microthrombi, which is being precipitated by intravascular coagulation. Apart from that, we all know the importance of microthrombi in terms of causing myocardial injuries. And how do we monitor it in our clinical practice? We have been measuring D-dimer in our patients of COVID-19, trying to find out patients who are at risk of thromboemboli. So why I'm trying to discuss all these things? I'm trying to identify patients of COVID-19 who need anticoagulation. Based on these risk factors, hemostatic abnormalities, and clinical outcomes like venous thromboembolism, hypoxia not responding to oxygen, myocardial infarction, and disseminated intravascular coagulation. So these are the group of patients in whom this coagulopathy is causing the major damage, and they have to be addressed. With all this background, European Society of Cardiology came up with the guidance that in management of cardiovascular disease during COVID-19 pandemic, full therapeutic anticoagulation should be done for prevention of atrial fibrillation related thromboembolic complications in men and women with high risk factors. We all know that when patient is hospitalized, we prefer to use low molecular weight heparin in therapeutic dosage. Despite anticoagulation with low molecular weight heparin, many patients with acute respiratory distress syndrome still develop severe thrombotic complications. Thus, there is need for full therapeutic intensity anticoagulation in patients with severe illness when anticoagulation is needed. Apart from that, we all know that there are chances of heparin resistance, which would require high dosage of heparin, and monitoring of APTT has to be done. In few cases, with the use of heparin, we have seen life-threatening hemorrhage. So, although we are using low molecular weight heparin, in our IPD cases, there are certain places where limitations do exist. And we need to find out that what would be the best anticoagulation measure in such cases. Now, let us understand the role of oral anticoagulants in COVID-19. We all know that chronic oral anticoagulation is essential to reduce the thromboembolic risk among atrial fibrillation patients. And we have been using oral anticoagulants in patients of atrial fibrillation since decades. Now, switching to low molecular weight heparin has been recommended during hospitalization, and at discharge, the prescription of direct oral anticoagulant has some advantage over the traditional vitamin K antagonists like warfarin and esacumeral or acetron. But oral anticoagulant should only be prescribed after consideration of drug and drug interaction with antiviral therapies and as well as risk of hepatotoxicity. We all know how much notorious warfarin is in terms of drug-drug interaction and CYP activation. We all know that hepatotoxicity has to be considered in the background of severe COVID pneumonia, because most of the time we do have deranged liver functions with increase in SGPT and SGOT showing damage to the liver during COVID-19. So we have to choose safer oral anticoagulant. Thus, the anticoagulant which has got good efficacy and good safety profile in terms of hepatotoxicity should be chosen, and dabigatran is one of them. Let us see what we do have results which was published in March 21 this year, only couple of months back. Use of direct oral anticoagulant reduced the probability of severe course and adverse outcome in development of coronavirus infection by SARS-CoV-2. So we have understood the pathophysiology, why a patient develops hypoxia, happy hypoxia, despite absence of acute respiratory damage, despite absence of heart failure. Patients of COVID-19 develop hypoxia, which is often called hypoxia, and we have understood the cause. And the results show that number of hospitalization was significantly fewer in groups of patients who had received direct oral anticoagulant. Hospitalization risk was around 20% in patients who received oral anticoagulant versus 66% who did not receive oral anticoagulant. So what we are trying to do is prevent hospitalization by adequate oral anticoagulation, preventing hypoxia. In this background, we need to understand differences in between different direct oral anticoagulants. And the most important is risk of drug and drug interaction, the way they are being metabolized. An increase or decrease in drug concentration caused by significant pharmacological interference is one of an important parameter, because you need to know that whatever dose that you are using is correct or not, and is it adequate or not. So there is no inhibition or induction of principal isoenzyme cytochrome P450 with dabigatran. Thus, drug-drug interaction with dabigatran is unlikely. However, rivaroxaban is substrate for PGP metabolized CYP3A4 about 18%. So use of rivaroxaban is not recommended in patients receiving concomitant systemic treatment with potent CYP3A4 and PGP inhibitors such as ritonavir, as they can increase the risk of bleeding. Similarly, apixaban is metabolized about 25% by CYP3A4. So use of apixaban is also not recommended in patients who are receiving drugs which has got effect on CYP3A or PGP inhibitors. Concomitant use of a strong CYP and PGP inducers may lead to a significant reduction in apixaban concentration and caution should be exercised because adequate anticoagulation will not be there. So, dabigatran may be considered as first-line choice for oral anticoagulation at discharge after COVID-19 because metabolism is by cytochrome P7450 is absent. There is low risk of hepatotoxicity, and dabigatran has a specific reversal agent. Now, this is another important thing that we need to understand. If there is over anticoagulation, which may predispose to bleeding, we should have something by which we can reverse the effect. And dabigatran is the only direct oral anticoagulant which has got agent which can reverse its effect. Some points which I would wish to repeat here, that other than dabigatran, direct oral anticoagulant have interaction with antiviral drugs like ritonavir and lopinavir. Concomitant use of protease inhibitor is contraindicated or not recommended with apixaban, rivaroxaban, and indoxaban. But in the case of dabigatran, there is no significant interaction. Thus, dabigatran can be used safely. So, apart from liver toxicity, let us understand what is the incidence of liver injury by different type of oral coagulant. This was once again reported in Drug Context September 2020. And you can see clearly from the graph that risk of hepatotoxicity is minimum with dabigatran. Incidence of hospitalization due to liver injury, once again, the same data is being presented. Dabigatran has lowest risk. Now we need to understand impact of non-compliance. At times, patient forgets to take medicine. So if I have a drug which is being given twice daily, probably non-compliance will not be an issue. So we can summarize that dabigatran is the drug of choice amongst direct oral anticoagulant in patients with COVID-19 due to its lowest risk of drug interaction and lowest risk of hepatotoxicity. Thank you very much for your patient hearing. Now I would hand over